Hi, my name is Dr. Juliet Sekabunga Nalwanga, and I am going to present surgery for brain trauma in this Kampala Advanced Trauma Care course. A brief overview will define a number of things like the bar holes, craniotomy and craniectomy. We'll briefly look at the skull anatomy and landmarks, the instruments, and then describe what bar holes are, the craniotomy, and then decompressive craniectomy. And this will describe in the context of trauma. Bar holes, simply, personally, they are holes drilled in the skull to access the intracranial cavity. These are my personal definitions. However, when you look at all the other research and papers and everything, everyone has a different definition, but personally this is the simplest definition I can define them as. Craniotomy, this is the removal of the skull bone flap, which is replaced after an intracranial procedure. And then craniectomy is removal of the skull bone flap, which may be or may not even be replaced later. So here in craniectomies, we remove the bone flap, allow the brain to expand out as much as possible, and then when the brain edema is relieved, we come back maybe 3 months, 6 months, or even a year later to replace the bone flap, doing a procedure called cranioplasty. So briefly, we look at the skull, we look at the frontal bone, the parietal bone, the occipital bone, the temporal bone, and then the sphenoid bone. So this is where most of the action happens. And then of course in the EP we look at the frontal bone, the sphenoid, the temporal, and a bit of parietal bone. So if we are to talk about the point where the parietal, the frontal, the sphenoid, and then a little bit to connect to the temporal bone, that point where these bones meet is what we call the pterion, and this is the thinnest part of the skull bone. Its significance basically is that the middle meningeal artery, after it enters the skull, it goes through foramen spinosum and then through into the sphenoid ridge, and it fans out. At this point, at the pterion, it fans out. So if this is the thinnest bone and we have fractures here, they will definitely cause injury to the middle meningeal artery, and this will end up into an epidural. So this artery fans out there, it fans out up there, and then fans out posteriorly. So any of these points where fractures traverse will actually cause an epidural hematoma. So if we look here, we basically look at the bone, what we've been describing in the first picture. So you have the sphenoid, the frontal, the temporal, the occipital, and then the parietal bones. So the instruments that we use to do bar holes, craniotomies, and probably craniectomies. So we have the Hudson brace. It's a hand drill or a manual drill. And then we have the perforator, and then the bar, and then the other instruments that are important, of course, the blade handles. We have the periosteal elevator, we have the mastoid retractor or the self-retaining retractor, we have the arteries, the scissors, and then the pickups, whether toothed or non-toothed pickups, and then the suction catheter, which is attached to the suction tube. So bar holes, why do we do bar holes? So partly the indications are intracranial bleeding. Usually we do them for chronic hematomas if they're done individually, but then commonly we do them to access the intracranial cavity. So before we do a craniotomy, the first thing we do is a bar hole, whether we do multiple bar holes and then connect them to do a craniotomy. So the other thing is that we can do them when we are doing an EVD insertion. Remember we described earlier that part of the management of head injury could be a ventriculostomy to drain off CSF. So you insert an external ventricular catheter. So this catheter goes into the ventricle, and then it's connected to a drainage bag out of the brain. However, if you can measure the intracranial pressure from it, and the pressures are higher than 20, then you can still use the external ventricular catheter to drain off some of the CSF to relieve the intracranial pressure. So the bar holes can be performed under local or general anesthesia, depending on what setting you're in and how unwell your patient is. Sometimes patients are so unwell that you can do it under local anesthesia, or you can still do it under general anesthesia. So it depends on where you're going to do it. We can do a bar hole there, the brow incision that we are going to describe. We can have the temporal bar holes there, or the sphenoid actually bar hole. You can do a temporal bar hole there. You can do a parietal bar hole, whether a linear incision or that transverse incision. You can do an occipital bar hole, and then you can do a frontal bar hole. So usually using the aseptic technique, we do local skin infiltration. If you're going to do it under local, definitely you'll use lidocaine, and then we do a 1 in 200,000 of adrenaline. Remember, the skull is very well supplied with blood. You have the supraorbital artery coming in, you have the superficial temporal artery coming in with the frontal, parietal, and a bit of branches going all the way. And then you have the occipital artery coming in to supply mainly posteriorly. So all these incisions, you have to make sure that you have what it takes to achieve hemostasis. Whether you have arteries or the self-retaining retractors, it is very important. So the incision is usually done through skin down to the pericranium and bone, and then once it's done, then we strip the pericranium. As you strip this pericranium from the bone, you will have better exposure, and you'll also have better bone drilling when the periosteum is stripped from bone. After you've done that, then you insert your self-retaining retractor, because sometimes you don't have enough hands to keep retracting for you, or sometimes the incision is really small and you can't have so many hands, trying to retract. So the self-retaining retractors come in very handy. So after you've done that, then you ask your assistant to hold the head, because this moves, as you apply pressure, it moves. So he sort of counteracts you as you're trying to make your bar hole. So using the Hudson brace with the perforator that we have seen previously, you make you drill the bone, drill the outer table until the inner table is exposed, and then when it's exposed, attach the bar. So the bar will enlarge your hole and further expose the inner table. So once the inner table is exposed, then you can use the periosteo elevator to remove that inner table, because it's really thin. Sometimes people have used artery forceps, and then sometimes people have used Kerrison roungers to remove the inner table. Remember, in children and the elderly, the dura is usually firmly attached to bone, so you need the periosteo elevator to strip dura away from bone, or you need a Penfield 3 to help you strip dura away from bone. So once you've done that, then you are ready to, open. So if you have a chronic epidural bleed, then it will definitely drain out because it's below the dura. However, if you have a subdural bleed, or if you're going into the ventricle, after you have made your opening, then you have to open dura. And once you open dura, if it's a subdural hematoma, it will definitely come out. If you have to go through the ventricle, then you will use a catheter to enter into the ventricle. So usually for the ventricular access, we use the frontal bar hole to access the ventricle. Okay. So make your incision as big as that. Let's assume that your fracture is there. Then you can make your incision and then expose your fracture and elevate it. We'll look at that briefly. So the incisions depend on the location of the bleed or depend on the location of the fracture. So if it's frontal, if you have a frontal bleed, okay, so like this bleed here, we usually prefer to have a hairline incision that runs like that. Or you can do a brow incision which runs like that. So because the supraorbital nerve runs through a groove there, we usually do the lateral 2/3 of the brow to avoid injuring the supraorbital nerve. And then when you make your incision, make the bar hole, you should be able to drain at least part of this hematoma. You probably won't drain a lot of it or all of it. So the best would be the hairline incision, which runs up to there. And then you make your bar holes probably posteriorly, and then drain the hematoma that would be there. So if it is a parietal hematoma, then our incision will either be a linear incision, just like that. Okay. It could also be a question mark incision, or you can do a horseshoe incision. We're going to see that briefly. If it's temporal, you can still do a linear incision, or you can do an inverted question mark incision. And then if it's occipital, then it could be linear or an inverted U incision, or what we'd call the horseshoe incision. So briefly, we'll look at what a craniotomy would entail. So this patient most likely had a parietal hematoma. Okay. So what we'd do, would outline. So you run your incision. So this is the horseshoe incision. So you'll run your incision like that. Okay. Or the inverted U incision. So you take on your incision down to galea, or you can take it all as one down to periosteum. And then as you do that, you will have your flap, raised off, and then you'll have bone exposed there like that. Okay. So with the bone exposed, then we make the multiple bar holes. Remember, we said that bar holes are points of access into the intracranial cavity. So it's like the initial hole that you need. So you have a bar hole there, you have a bar hole there, you have a bar hole there, you have a bar hole there. So still imagine you had a depressed skull fracture about there. So you can still do the same, make your multiple bar holes, and then using an electric drill or a jiggly saw in our setting. So the jiggly saws would go between the bar holes, and then you cut out this bone. Okay. So after you have removed the bone flap, so what do you want to do? Do you want to evacuate an epidural hematoma, or do you want to evacuate a subdural hematoma? So in this case, this was a subdural hematoma. This is a subdural space. So if you remove the bone, so if we take out this bone, take out this bone like we see it. Then if you have an epidural hematoma, it should be under the bone, so it should be where, it should be removed immediately because it's under the bone. So in this patient, it's likely that they wanted to look at what was below the dura, so they opened up the dura and they were able to expose what was underlying the dura. So after you've done that, then you have to suture the dura back and then replace the bone. Okay, so and then close. So this was basically a craniotomy. We just remember skin to bone, multiple bar holes to take off the bone. So bone is off, and then if it's an epidural, you should be able to evacuate it. If it's a subdural, open the dura, evacuate it. After you've done so, then suture back the dura like they did there, and then replace the bone. So this is what we'd call a craniotomy. Okay, we took off the bone, evacuated a hematoma, and then replaced the bone and closed the skin. Okay. Okay. So imagine if a patient has such a big depressed skull fracture. What do you want to do for them? So in this case, with a patient with such a big depressed skull fracture, you're likely to need a very big incision in order to expose this fracture. And here your incision may extend past the midline so that you can be able to expose that whole bone fragment. So what we can do here is that if you have a point that has normal bone, okay, so that could be normal bone, or posteriorly that could be normal bone. So for us to choose where to put the bar hole, we try to avoid the midline because the superior sagittal sinus runs there. So I would not advise you to put a bar hole in the midline. So we'll choose a point like there, okay? So you make your bar hole and then you slowly start elevating this fracture. So because there are multiple fragments, you may have to remove all these fragments slowly, okay? Remove one by one, slowly. Remove that next fragment, remove that, and then remove all these. Why are we doing this? So the basic thing is that we want to make sure that we can expose the dura, because if you don't expose the dura and this patient has a CSF leak, they might actually end up with intracranial sepsis if the dura is not closed well. So what we would do is remove all these bone fragments, and then of course there are some fragments that may be within the brain, so you may need to remove them slowly, okay? So after you've removed them, then you decide. So we have to close the dura, and if we are to close the dura, we may need the pericranium. So usually in these procedures, we save the pericranium to act as our dura graft, or if you're in a very good setting, then you may use a dura graft. There are dura grafts on the market. So after you've removed this bone, if the brain is not herniating through the defect, then you can loosely put it back so that he does not leave hospital, with a craniectomy. However, if you've done this and the brain is herniating through, then you may decide to save these bones for the time when you'll come back for a cranioplasty. Or sometimes the fragments are so out of shape and they really can't be replaced, then we may have to discard them and then advise the patient that we will need to do a PEEK implant later on in life. So briefly, The incision is quite large for some patients, so for some patients we may just take it there. So 0.5 centimeters from the tragus of the ear or to 1 centimeter, but you have to palpate for the superficial temporal artery because it supplies the scalp. So you take it up above the ear. So for some, we take it up to there. If we think the edema is worse, we may extend it to the occipital bone and then bring it back like that. You have to be very careful. You have to remember that the transverse sinus is running there, so our incision usually doesn't go up to the transverse sinus, so we go short of where the transverse sinus is. So we would run it like that, and then we bring it up to the hairline. So some people may tell you that the incision may cross the midline. Some people may say you can keep it about 2 centimeters from the midline. It's still all okay. The people that say that you can take it across the midline believe that when you're exposing your bone, you can clearly see the midline and avoid, to tamper with the superior sagittal sinus, which is actually running in the midline. Okay, so there so there you can see that's temporal, so that's parietal, that's frontal. And then if you need to go down, you may extend like that, but give room for this transverse sinus, avoid encroaching onto it. Okay, so with a headrest, so we place the head on a headrest, asepsis is observed, we outline the incision like we've outlined previously, and then we use 1 in 200,000 of adrenaline, and we make this incision. It's usually the standard trauma incision or the standard inverted question mark incision for trauma. So it's made down to bone, raising a myocutaneous flap to expose the frontal, the parietal, and temporal bones, and sometimes, if the edema is worse, the occipital bone. So multiple bar holes are made, and then those are connected with a drill or a jiggly saw. And of course, there are areas that you may not be able to connect with a drill or jiggly saw, where you may need a bone nibbler or a Kerrison ronger to drill away the bone, depending on how much space you need. So the bone is removed to expose dura, and then if you still have an epidural over that dura, you can remove it. And then a dura incision is made. Usually it's a cruciate incision, but depending on where you are, some people may just make multiple dura incisions. So if you have a subdural hematoma, it's drained at this point. And sometimes the brain is really edematous, like we described earlier, that when you have subdural hematomas, usually it's the bridging veins that are injured, and therefore because the cortical veins drain into the bridging veins, and then the bridging veins drain into the sinuses, the superior sagittal sinus. So if the bridging veins are injured, then the cortical veins will not drain well, and therefore that will cause edema. So if the brain is edematous, it will definitely herniate above the bone edge, and at this point, usually the brain is pulsatile. You'll see it pulsate if there's still, blood flow to the brain. Or at this point, actually, it may be like the beginning of a return of blood flow into the brain after compression from, the bone, the rigid cavity. So sometimes we may advise you to close or not close dura, depending on what's happening. Sometimes you're trying to do this operation so fast, relieve pressure and then come out. And so sometimes we may close dura if we if we are comfortable and we have time, but sometimes we may not close dura, so we may lay pericranium over the dura defect, or we may lay a dura graft over the defect and then close skin. So with a brain edematous, we cannot replace the bone, okay, because we want the brain to expand out, we want restoration of blood supply to the brain, and then we want to give it room to restore to its original function. So bone may be stored in a bone bank if you have one, but otherwise we usually make an abdominal incision and then store this bone in the superficial abdominal fascia. So later, probably after 3 months, 6 months, 1 year, we come back and open up this incision, and then both incisions, and then get this bone and replace it back, a procedure that we call cranioplasty. So this is what we have been describing. So you have your standard incision, the standard trauma incision, which is an inverted question mark incision, okay. And then one thing that I had forgotten to mention is that the craniotomies that we do on the left side are usually smaller compared to the craniectomies we do on the right side, because the left side is a dominant hemisphere. It's an eloquent cortex, so we are sort of limited to how much we can expose of the brain. Because one thing you have to remember is that even when we remove this bone flap, sometimes patients come back with constant headaches, things that can't go away, things like weakness that can't be explained, sometimes seizures, and so they sort of get what they call the syndrome of the trephined. So this is basically sorted out when you replace the bone for some patients. So we are very vigilant when it comes to the left cortex, because it's eloquent. Therefore, the amount of bone flap we remove is quite limited compared to the right side of the brain. So basically incision down to skin, like now we can see. And then if you have an epidural, it would be, down to skin, and then remove the bone flap, okay. So if you have an epidural hematoma, you definitely would find it there, okay. So we open dura like they have here, okay. So dura is opened even there, okay, and then even there it's opened. So if you have a subdural hematoma, it should come out. Sometimes even when you open, you can see contusions, you can see subarachnoid hemorrhage, and then of course you will not do anything about it, and then of course you will observe your brain expand out, okay. So it may expand above the bone edge, which is okay. So after we've done that, then we may decide to close dura or not, lay the pericranium over dura, lay a dura graft, and then allow the brain to expand basically. Then just close the incision, the scalp incision. So basically these are bar holes that we've been explaining, okay. And then the bone flap is taken off, the dura is exposed, and then the dura is opened up, okay. And then after you've done all that you've done, then you close the skin. You can close the skin with staples, you can close the skin with sutures, whatever is available for you, okay. So this is briefly what I can describe about the bar holes, which the take home is that they are basically the holes that give us entry into the intracranial cavity. Basically, even when you have a very good drill, the first thing that you'll always start with is a bar hole. Okay, so you can drill all this away, but this is the main thing, the bar hole, to give you access into the intracranial cavity. And then the recap is a craniotomy, is when we remove a bone flap and replace it after the intracranial procedure. So let's assume that we removed this bone flap. We had an epidural hematoma there. Okay, after removing the epidural hematoma and the brain is not so swollen, we replace the bone flap. And then decompressive craniectomy, where if we open dura and the brain is herniating above the bone surface, then we cannot replace the bone. We will store it in a bone bank to, bring the patient back later to replace the bone. Thank you very much.